Thank you, Professor Kato. And maybe it's 3+6 already, so we can start our ACNS YNS webinars today. So today, good morning, good afternoon, and good evening, everyone from all over the world. And thank you so much for attending this ACNS YNS webinars. So today, chairs will be Professor Abhidharsh Shah, who is the Assistant Professor in Neurosurgery, 𝑪𝒉𝒂𝒄𝒄 Medical College and KIM Hospital in Mumbai, India. So we have 3 speakers today. Our first expert speaker is Professor Chiara Ruba, who will be talking on intracranial pressure monitoring and management. Professor Ruba is the anesthesia and intensive care IRCCS Policino San Domenico Genova, Italy. He's also the chair of the Neurointensive Care section of European Society of Intensive Care Medicines. Our next speaker is our YNS speakers, who is Dr. Ahmed Eden 𝑹𝒐𝒃𝒃𝒂. I'm sorry for the pronunciation. And he's the consultant neurosurgeon and chairman of the neurosurgical department in neuroscience hospitals in Iraq. His topic is the safe entry zones of the pharmacist. Our third expert speaker is Professor Abhidharsh Shah, who will be talking on advances in cranio-vertebral junction surgeries. Professor Abhidharsh Shah is the assistant professor in neurosurgery of the 𝑧𝒉𝒂𝒄𝒄 Medical College and KIM Hospital in Mumbai, India. Our discussant today is Professor 𝑦𝒏𝒕𝒓𝒂𝒄𝒓𝒂, who is the scientific secretary head of Laboratory of Biomedical Informatics and Artificial Intelligence (R&D) Burdenko's Neurosurgery Center in Moscow, in Russia. The next discussant today is Professor Ahmed Farid-Pirzad, who is a professor of Kabul University of Medical Sciences and the chief of Neurosurgery Department of Aligarh University Hospital. He's also the president of the Afghanistan Neurosurgical Society. To moderate the session with me, we have Dr. Sachin, me, Ben, and also Dr. Atik, Dr. Joey Sam, Dr. Biswas, and Dr. Sugiti. So without further delay, shall I invite our chair today, Professor Abhidharsh Shah, to introduce our speakers. Thank you, Professor.
Thank you, Ben. Let us start the webinar today. And for the first talk, I would like to invite Professor Chiara Ruba for her talk on intracranial pressure monitoring and management. I think it's a pre-recorded talk, and I think Ben is going to play it, right?
Yes.
Okay, so we can start.
Sorry, I'll start now. Can you listen to me well? And can you see the screen?
Yes, we can.
Yes.
Okay.
Please start.
Okay, sure.
Hello to everybody, and thank you very much for the invitation to give this talk. I'm Chiara Ruba from the University of Genoa, and we will be discussing about ICP monitoring and management. I have no conflict of interest for this topic, and this is a sort of agenda regarding what we are going to discuss. We will treat the importance of monitoring and treating intracranial pressure and intracranial hypertension, the targets of ICP, when and how to monitor, and then we will focus on the treatment principles for this topic. So this is the waveform analysis. Every time there is a patient with an invasive ICP probe, it's very important to look at the waveform analysis because it can really provide important information on intracranial compliance and intracranial pressure. And as you can see here, a normal waveform of intracranial pressure has 3 different waves. P1, which is the percussion wave, the arterial one, which represents the arterial component, P2, which is the tidal wave that represents intracranial compliance, P3, or dichrotic wave, which represents aortic valve closures. And this is what happens when there is a lot of compliance. This is clearly a patient who has some intracranial issues. And here you can clearly see that P2 becomes higher than P1, and the intracranial compliance is importantly reduced. So this is a very important point because the brain is inside the skull, and within the skull, it's basically a closed box, and there are different systems which allow to compensate when there is something that happens, like a brain injury and hematoma, etc. And the pressure inside the brain determines a pulsatility, which is then seen in the venous, in the arterial, and the CSF compartment. And we need to be careful not to look just at the number, but also to consider all the above things that I have mentioned, because this is the very, very famous PV curve. Here you have the pressure, here you have the volume. Here you have a patient where something is increasing, the volume is increasing, but the mechanism of compensation are working nicely, and this means that the pressure does not change. But here what happens is that changes of small volumes cause changes of intracranial pressure, but this means that we are already in a phase where the mechanism of autoregulation and compensation are basically exhausted, and it's very, very late, and it's here where you see this ICP waveform which changes, and you see P2 higher than P1. So it means that all the things that are in stage 1 have already happened. And this is why ICP has to be treated importantly and aggressively. So this is the very famous, the only randomized controlled trial on this topic by the group of Chestnut. Everybody has spoken about this trial, and it was a randomization of patients with brain injury before 24 hours, 48 hours from the injury, and they were randomized in ICP monitoring or only clinical and imaging examination. This trial was negative and caused a lot of discussion, but there were some issues related to the underpowered of the trial, the type of clinical management and settings. And basically what we have learned from this trial is that we cannot think about correlating a monitor with an outcome, because it's important not just to monitor, but to manage intracranial pressure. So it depends on what the clinicians do to treat intracranial hypertension. And this is the model of a synapse ICU study, large observational study with more than 2,000 patients, where basically what we discovered is that there is an association between intracranial pressure and mortality, and the use and treatment based on invasive ICP is associated with improved outcomes, especially in patients who are severe, so who have alteration in the pupils. Now, regarding the indications, these are the guidelines from 2007, indication for ICP monitoring, and they stated that severe TBI with a GCS of 3 or 8 with abnormal CT scan were amenable for invasive ICP monitoring, and also other types of patients according to the risk and the severity of the injury. The new guidelines, they just say that the recommendation from the previous edition are not supported anymore by the evidence. So basically they have challenged the previous indications for ICP monitoring. And this has caused a lot of variability in terms of insertion of an ICP bolt. This is a caterpillar plot from the Synapse ICU study, and each one of these dots is a center, and this means that basically each center, each patient with the same characteristics as 4.5 times the risk or not to insert ICP, just based on the type of center where he is admitted. So it means that there is huge variability across different centers. And the other issue is about the threshold. We know from the guidelines from 2007 that the famous 20 of ICP is at risk. So this means maybe that when ICP is 19, we can get some rest and have a coffee. And when it is 21, we need to jump at patient's bedside. Of course, it is not how it works. The new guidelines, unfortunately, didn't sort this issue out, because they just said, well, it's not anymore 20, but it's 22 millimeters of mercury. And the reason why we say this is because there is a very well done retrospective single center study, which is this one, and it's a very nicely performed study, but it's one study where basically, as you can see here, the chi-square associated with higher mortality and worse neurological outcome is at 22 millimeters of mercury and not to 20. So this is why the new guidelines have changed the threshold. But the point is that regardless the 20, the 22 of ICP, the problem is the dose. The problem is for how long a patient stays with a high intracranial pressure, because this is an example, this is a very nice study, and which demonstrated that it is the area under the curve that is related to the outcome. It's not the single number, but it's the dose of intracranial pressure. And everything I said is also importantly highlighted by the recently published guidelines of SINC NCRT, which is the Neurosurgical and Intensive Care Society of Intensive Care, where all this is basically summarized. And then there is the treatment. The treatment of intracranial pressure is an escalating treatment. You have to think about a staircase approach. First of all, what you have to do to treat intracranial pressure is basically to be a good general intensivist. This is what is called in the guidelines a tier 0. It means that all you have to do is to optimize physiology. Of course, it seems easy, but it's not in the reality to optimize physiology. With Fabio Taccone, we created this acronym, which is the GOSCAP, that basically help to keep in mind the different points that you need to consider when you treat a patient with acute brain injury: glycemia, hemoglobin, oxygen, sodium, temperature, comfort, arterial blood pressure, CO2, etc. And then only when this first step has failed, you have to go at tier 1, at the first step, where different things can be done. For example, to lower a bit the PaCO2 to 35 to 38 millimeters of mercury, boluses of mannitol and hypertonic saline, CSF drainage, etc. All these factors can be used, are relatively safe, but don't forget that each one of these factors has anyway some risks for derangement of osmolarity, reduction of CPP, for mannitol, for example, hypernatremia. The risk and the benefit of CO2 manipulation have to be taken in consideration. If these do not work, then we jump to tier 2, which are more aggressive treatment. And here, basically, there is a more deep target of carbon dioxide, 32, 35 millimeters of mercury, neuromuscular paralysis, and the MAP challenge to assess the autoregulation. The latter one is basically the most pragmatic way to assess autoregulation that we know is a very complex phenomenon. Basically, if you increase the arterial blood pressure here and you have a reduction in the ICP, it means that there is a vasomotor response in that moment. So it means that that is the arterial blood pressure at which the patient is autoregulating properly. If you do this test, and when you increase arterial blood pressure, you have an increase of intracranial pressure, it means that you are outside the limit of autoregulation. It's a simple but complex at the same time finding. So this is what you have to think. Staircase approach, each step that you take takes some more risks, but of course, if these are necessary to treat intracranial hypertension, especially when it is refractory, these need to be done until arriving to the very famous tier 3 strategies, which are the use of barbiturates, decompressive craniectomy, and hypothermia. You will see that profound hyperventilation is considered outside from this because it is considered just a rescue therapy, only when the patient is at risk of herniation. And the reason is that what we have learned from different studies, included this one from a group of Cambridge, is that when you go too deep with CO2, you have an increased risk of ischemic area in the brain. But look at the target, 25 millimeters of mercury, much lower than what is suggested by the guidelines. And in fact, when we use other types of targets of CO2, actually things seem to be safe. This is a center TBI study on carbon dioxide values. Again, we can see here a huge variability, but the median value of CO2 in TBI patients is around 37 millimeters of mercury and even lower in TBI. So it means that the physicians follow the guidelines. But what is important from this paper is that the centers who tend to use hyperventilation have not a worse outcome compared to the other centers. So if we keep if we stick to the targets recommended, we should be in a safe areas. Regarding the tier 3 therapies, the more aggressive ones, hypothermia has been challenged over the last years. This is a randomized control trial, the Eurotherm trial, which compared hypothermia with stage 2. So because we are still in a very early phase of TBI management, the results of this suggested a worse outcome in the hypothermia group. But again, keep in mind that here hypothermia probably was used too early. So what we see here are the side effects. This is a study which studied the prophylactic hypothermia, and it was basically a negative study. And regarding the decompressive craniectomy, this is the DECRA study. This is a very nice study, randomized control trial, where the compressive craniectomy was performed after 15 minutes of increased intracranial pressure, and basically the patients who were randomized to early decompressed craniectomy had the good, probably a better control of the intracranial pressure, but this was also related to worse outcomes. And this suggests that if we use these strategies too early, in the early phases, we mainly see the side effect without having a clear good effect on the outcome. And this study, which did basically the same thing, but in a later phase, so he studied the compressive craniectomy just as a rescue therapy. So when everything else has basically failed to treat intracranial hypertension, this is the algorithm of the study, and you can see the randomization occurs at a stage 3. This study, in fact, confirmed the fact that there is a significant improvement in mortality in patients undergoing the compressive craniectomy. So this suggests and confirms this star case approach. Tier 3 strategies should be considered only when the other treatments have failed and in case of refractory intracranial hypertension. Then, what to choose when you are in the moment of tier 3 therapies, it really depends on the type of patients, because if a patient has the potential for good neurological recovery, I will go for the compressive craniectomy. Otherwise, I will be a bit more reluctant. I would try barbiturates or hypothermia. So, in conclusions, we can say that the intracranial pressure monitoring can improve the outcome and is a standard of care for neurocritical care patients. The clinical approach is based on a star case approach. We have to consider that each thing that I do can lead to potential risks. Second and third 3 therapies should be evaluated case by case and only when previous strategies have failed. Thank you very much for your attention.
Thank you, Chiara, for this wonderful insight on intracranial pressure monitoring and when to use it and at what point you should escalate the therapy. So, should we have questions now?
Yes.
Yes, okay. So I'd invite first our discussions, Dr. Gleb and Professor Ahmad for their comments and questions.
Thank you. Am I allowed to speak?
Yes, go ahead.
Thank you. Thank you so much for a wonderful lecture and the introduction of ICP science, which is really complex, and we still deal with the tip of the iceberg when we're trying to explain the outcome of traumatic brain injury based on intracranial pressure and autoregulation state. We're still putting together pieces of puzzle to understand this complex physiology of cerebral circulation, ICP regulation, so to put together some kind of the picture. And there are many questions, still many questions. The guidelines are constantly being adjusted with new data. But a very interesting insight, and what I would like to ask, if I'm allowed to, there are 2 points that come to my mind about the discussion. What do you think about the new methods of intracranial pressure monitoring, such as optic nerve diameter as a correlate of intracranial pressure. And since the problem of autoregulation, or I would say a wider problem of regulation of cerebral blood pressure and optimal perfusion pressure, what do you think about cerebrovascular reactivity in certain patients as important targets to study? Because we still try to explore autoregulation as a rough correlate of intracranial pathophysiology. But the regulation of cerebral blood perfusion is much more complex, and the reactivity might be also the target. So what do you think about these 2 points? Thank you.
So thank you very much for the questions, and thank you very much again for the invitation here. So let's start from the first point. Both of them are really excellent points. So the first one is about other surrogate of intracranial pressure monitoring, so the non-invasive methods. I have started more than 10 years ago. My PhD was exactly on ONSD and on non-invasive neuromonitoring tool. And the idea when I started, you know, I was a young student, was to find something that could replace the invasive ICP monitoring and that was safe, bedside, and easily available. What I have learned in these 10 years is that so far we don't have a non-invasive monitoring which is accurate enough to substitute the invasive ICP monitoring. But despite this doesn't mean that the non-invasive monitoring have to be abandoned. Actually, they have a very important role. For instance, you mentioned the ONSD, but there are now the pupillometer, the transcranial Doppler, there is the evaluation of the cerebral compliance, different methods. They can be used in different ways. One is together with ICP monitoring because they help clinicians to understand the pathophysiology of brain injury. So it's not just about intracranial pressure, the problem. You mentioned the cerebral vascular reactivity, for instance. Transcranial Doppler can help a lot to understand whether this is preserved or not. And I think it's very important. So they can help clinicians to understand what is going on. ICP, as mentioned, is a number, but should not be considered just as a number. If I have an 18 of ICP, but I see a bad compliance, a bad transcranial Doppler, a bad ONSD, I will be very cautious in weaning the patients. Probably I will not. I will wait. So they can be used together with ICP. And then don't forget that there are so many conditions. I like to call them the gray zones, where ICP is contraindicated, the ICP is not available. The indications we have seen that the guidelines are so not precise in giving us suggestions. So there are so many situations where ICP is not super indicated, but you would like to know what is happening in the brain. So in these conditions, the non-invasive methods to me are perfect because they can help you to guide you together with a clinical assessment and together with a neuroimaging. And to get regarding the second part of the cerebrovascular reactivity, that is a fundamental component, I think, of the assessment, because it really gives you the idea of how much the cerebral vascular function is maintained or not. The cerebrovascular reactivity is a unique, proper characteristics of brain vasculature. So if it is impaired, it means that the brain is well damaged. And it is strictly correlated to autoregulation, but the major determinant of that is the PCO2. There are so many studies which have suggested the manipulation of CO2 to regulate the cerebrovascular reactivity. Some studies have also suggested that the mild hypocapnia can help in improving the vasoreactivity. So far, we don't have any study which correlates this with the outcome of a patient. But in our field, it's really difficult to find level 1 of evidence. So sometimes we have to trust the physiology and trust what we do at the bedside, despite we don't have a level 1 of evidence. I think it's very similar to many other fields, but for us, it's very clear this. Thank you.
Thank you so much.
Ben.
Professor Pirzad?
Thank you, Professor Ruba. Thank you very much. This is Dr. Pirzad from Afghanistan. And I'd like to know your advice for which countries like Afghanistan, we don't have ICP monitoring. And what is your advice for clinical guiding of ICP monitoring? And also, like previously it was Cushing triad. And do you advise some clinical facts that we take care of ICP? Thank you.
Thank you so much for this question, because it allows me to spoiler a bit about what is going to happen in the next months, because we are concluding an international consensus on the management of TBI patients when ICP is not available. This consensus is based on the 𝑬𝒐𝒃𝒃 protocol that you probably know it, which is based on clinical assessment, so GCS and pupils, and CT. And we added on top of this the non-invasive methods. And we added the pupillometer, transcranial Doppler, pulsatility index, and the formula based on the flow velocity diastolic and the ONSD. And we have created an algorithm, a clinical algorithm. What we have learned from this work, which I hope will be published in the next few months, is that the king of the assessment is always the clinical assessment. That the neuroimaging can help, especially in the first phases. And the third point is that the non-invasive methods, as I was mentioning before, can help especially to raise the suspect or to exclude intracranial hypertension. So don't trust the non-invasive method as a number. So you don't, but you don't need it. I mean, you don't want to know if ICP is 13 or 14. Who cares? I want to say, you want to know if the patient is worsening, if the brain swelling is worsening, and if you have to treat it. So this is my advice, and I really hope that this algorithm will be useful. Of course, it is just a proposal, so we will need a validation study, and if you are available for the validation study, it will be really great to collaborate on this.
Thank you very much.
Yes, Ben?
Yes, first of all, thank you, Professor Robert, for your expert opinion on the management of ICP. Actually, I have some questions. So in our unit, we so far in our in my unit we don't use cerebrovascular reactivity or pulsatility index so far. So I saw in your lecture, and I'm quite interested into it. So I know you have software to calculate it, and usually, what is your tips to starting to measure this value, and how do you incorporate this value into your clinical management in your daily practice? Also, from the nursing staff perspective, would there be a huge burden to the nursing staff, or a huge burden for them to start to use this index in a daily practice? Another question is about nowadays when talking about the ICP, some always come in hands would be talking about brain tissue level, oxygen level, to as one part of the algorithm as stated as the SIBICC algorithm. So what is your opinion to monitor the brain tissue oxygen level? And do you think it's worthwhile or easy to measure, or you think that it could be more is getting more and more applicable and to our daily clinical practice. Thank you so much.
Okay, thank you very much. So regarding the first question, I think you mentioned the 𝑝𝑒𝑟𝒔. We do have the 𝑝𝑒𝑟𝒔. We are lucky. It's a nice software. It's expensive, I have to say. Basically, the concept of the 𝑝𝑒𝑟𝒔 is that if you correlate the changes of arterial blood pressure with the changes of ICP, you can find a correlation which tells you which is the CPP optimal. So where is the range of CPP at which the patient is autoregulating at his best? This, to me, is a wonderful concept. It's a concept which comes from the group of Cambridge, which Marek Czosnek, Peter Smelewski worked a lot on this. And there are many evidence in terms of observational, retrospective, and prospective studies. And there is one feasibility and safety study. I'm not sure there will ever be the phase 3 study because it requires a huge number of patients, and I'm not sure it is completely feasible. But the concept is fascinating to me. And in terms of clinical approach, the potential is the following. If you have a machine who is telling you which is the CPP optimal of a patient, let's say it is 75 millimeters of mercury, you adjust your arterial blood pressure in order to have that CPP optimal. There are many doubts regarding the fact that the trial on feasibility, it was a positive trial, I mean, statistically, because the initial plan was to achieve a feasibility of 33% of the measurements. From a clinical perspective, the results, which is the fact that it is feasible in 75% of the cases, is not a great achievement, because it means that once every 4 times, the number that I see in the machine might not be correct. So this, to me, has been as a bit confused the idea of the 𝑝𝑒𝑟𝒔. So I think it's a good index. I think it can be used, but with a lot of cautions. On the other hand, if you don't have the software, there is a much simpler, straightforward, pragmatic, and cheap way to assess cerebral autoregulation, which is what the guidelines are telling us. They tell us, if you have any doubt, do a MAP challenge. If you increase the blood pressure and the ICP goes down, it means that you have a preserved cerebrovascular reactivity. And that is the MAP target. Okay, it's something so easy and which can be done at the patient's bedside. Another way is the carotid compression. It's a test of carotid compression. I mean, there are a lot of less sophisticated, and for sure, these are not quantitative evaluation. It's just a yes or not, the patient is autoregulating or not. Whether the 𝑝𝑒𝑟𝒔 can give you a quantitative approach of how much it is impaired, but you can still do it. Okay, so it's feasible.
I see. Thank you for your valuable opinion.
Okay, I think Dr. Mathuria has a question. Sir? Sir, you're muted.
You're muted.
Hello. Yes. Thank you, Abhita. Say one question, and there are few comments. What is the reliability of transcranial Doppler to decide about the ICP? That is the question.
Okay, so we have just concluded the systematic review and meta-analysis on this, exactly focusing on the thresholds. Okay, so regarding the accuracy, the points that we took regarding the transcranial Doppler were 2. One is the pulsatility index, and one is the formula which is modified by ASLID, but which basically it is based on the flow velocity diastolic. Both formulas have obtained a sensitivity and a specificity of at least 77%. So quite good. Together with this, one important point is always to consider the CO2 values, because as we mentioned before, transcranial Doppler is very often influenced by CO2 values. So if you compare two values of a transcranial Doppler, always compare it with a stable CO2. This is the first suggestion. So in my opinion, transcranial Doppler is useful, and if you look at the literature, it is also accurate. The only problem with transcranial Doppler is that you have to know how to use it, because there is an intra and interoperator variability, which is the same for ONSD, which is the same for many other techniques. So you have to make sure that you do it properly in terms of evaluation of a blood pressure, CO2, technical angle of insonation, and all these tricks, where you insonate, etc. The problem with these methods, in my opinion, is that they really seem very easy. So you go to a course, an echo course, and in one day you understand how to insonate the middle cerebral artery, which is the reality. But the difficulty is the interpretation of what you are doing. Okay, and this to me is not easy at all, and requires a lot of training. However, having said this, I think it's something that in practice can really help you a lot.
Okay, thank you, Sarah. Abhida, there are a few comments based on this also. Say, like, it is extremely difficult to record the ICP quantitatively straight in all the traumatic brain injury or the patients in whom we expect that they will have raised ICP. So, as you have told that it's almost 70% reliability of the transcranial Doppler, what I feel, it's not a very big module to have. It should be there at a place where you are getting lots of the patients with the raised ICP in the emergency itself. And learning about the mean flow velocity insonation of middle cerebral artery is not a very great thing. It can be learned in a day or two, so that can be done. Then about the, you told about the CO2. If you think about lowering the ICP, I think there cannot be a better module than CO2 lowering, which will reduce the ICP drastically. So when we are when the patient is intubated, we can record the end-tidal CO2 and see what is the PCO2, and subsequent recording can be the difference between the PCO2 and end-tidal CO2, which we have recorded earlier. So all the time you are not to record the PCO2. That is one comment. The other is that in neurosurgery, we have seen in many critically sick patients, neuromuscular paralysis nowadays is avoided. We give lots of sedation, and which include even propofol, which will reduce the ICP as well, and it will give rise to lot of the sedation to the patient along with fentanyl. Barbiturate coma is also, it should be the terminally, it should be given the last resort, because the thing is that you can achieve a lot with the propofol and fentanyl, or maybe midazolam and fentanyl, and hardly it is required, because coming out of barbiturate coma, it takes a very long time. Then about the hypothermia, if you do a moderate hypothermia to 30, 33, 34 degrees centigrade, it will not cause much of the problem. It can be done by local cooling, it can be done by putting the fluids in the Rice tube and all those things and giving comparatively colder fluids. And say, when the patient comes to the emergency, on the radiology and the clinical status, one should assess that what is the likely the ICP should be. And then we should not exhaust any ways to lower the ICP along with your TCD value, which you have told, and the CO2 monitoring. So the raised ICP doesn't last for a longer time and leading to the irreversible changes. That's what my comments are. I think, Shara, you will agree to that.
Absolutely. I just wanted to mention, for the sake of time, I didn't go into details regarding the hypothermia. There are very, very I think, nice studies which demonstrate from a physiological perspective that ICP goes really down when you treat fever, of course, which is fundamental. But when it arrives to 35, then there is a sort of plateau. So we don't need to go to 32, 30, 33 degrees. And this helps us a lot in terms of side effects. And as you mentioned, now there are a number of devices which I think we are going to try them. We didn't try them yet, but I'm very positive about these. The collars, for instance, where you can, or the helmets, where you can cool only the head, and this really would allow, I think, to reduce the side effect of hypothermia, which scare a lot physicians, because to me, from a pathophysiological point of view, hypothermia really makes a sense in this population because it has a huge effect on metabolism. So,
And one thing is the serum osmolarity must be maintained all the time. If the serum goes hypoosmolar or hyperosmolar, then it's a problem.
Yeah, absolutely. This is a good point, because you have to assume that in the majority of these patients, the brain-blood barrier is altered.
Yes.
So you have to make sure that you keep the water in the intravascular areas, and it doesn't go in the parenchymal areas, in the brain parenchymal
So
area.
isoosmolar fluids are to be given. That is very important. Okay, thank you. I have taken your time.
Thank you, Dr. Chiara. And I think we should move ahead now in the interest of time. So I would like to invite the next speaker, Dr. Ahmad Adnan, and he's going to talk on the safe entry zones of the thalamus.
Sorry, I think we don't have Dr. Ahmad here. He's not online yet. So maybe shall we move to your talk first, and I'll try to communicate with Dr. Ahmad through email.
Okay, just a minute.
Yeah, thank you. Thank you so much.
Okay, can you see my screen?
Yes.
Yes.
Okay. So I'm going to be talking on advances in craniovertebral junction surgery. Before I show the technique of surgery, I'll just touch a bit on the concepts and the anatomy. So this, as we all know, is this beautiful junction, the junction of mobility and stability, the stability being provided by the occipito-cervical joint and the mobility being provided by the atlantoaxial joint. The other important thing in this area is there's this huge venous plexus around the vertebral artery, and this area can actually be compared to the cavernous sinus of the intracranial compartment, where the cavernous sinus has the internal carotid. This one has the vertebral artery. The cavernous sinus has a huge venous plexus. Here you can see the huge venous plexus around the vertebral artery. So these are the bones in the region that make up this junction. So the main one is the occipital bone. The parts of the occipital bone are the occipital condyle, the squamosal part, and the sphenoid part of the clivus. And the other two important bones are the C1 and the C2 vertebrae. So as you can see, they are both atypical vertebrae. The important one here is the C2 vertebrae, where you see that unlike other cervical vertebrae, the joints, superior and inferior joints, are not in one line. They actually are at an angle to each other, and they have this area around the bone and around both of them. And the other important point is this vertebral artery, which is going into the foramen of the superior articular facet. So this is the anatomy. There are some critical structures here that have to be protected. You have to know the course of the vertebral artery, the course of the pica, where it is arising from the vertebral artery, the C2 ganglion and its relation to the C1, C2 joint, which you can see here. This is the C2 ganglion, and this is the C1, C2 joint. And for the first time, as we all know, Professor Goel described cutting this ganglion, and it kind of became a window to the atlantoaxial joint because it gave access to this region during surgery. So here you can see it more better. So this is the C2 nerve root coming out here. This is the C2 ganglion, and just underneath that, you can see the C1, C2 joint. Here you can see the vertebral artery that is coming out from the C2, going above the C1 transverse, C1 posterior arch and entering into the intracranial compartment. And intracranially, this is the relation of the vertebral artery to the cranial nerves, the lower cranial nerves, the hypoglossal nerve, and here, of course, the 7th, 8th. These are the lower cranial nerves, and this is the spinal accessory which is coming here and joining. This is the hypoglossal nerve complex, and this is the spinal cord. At this region, the anterior spinal artery will actually come down and run on the ventral aspect of the spinal cord. So with a review of this basic anatomy, let's go on the technical and the philosophical aspects of the craniovertebral junction surgery and how we have now advanced in the thinking of this region, to actually treat a lot more pathologies in the C1, C2 region. So this was this technique of C1, C2 fixation. It is a C1 lateral mass, one screw in the C1 lateral mass, one screw in the C2 pedicle, connected to each other by plate. This was described by Professor Goel in 1987. And this is the technique that we are also currently using. So just a few examples. This is the C1, C2. You can see this is a increase in the atlantodental interval. This is flexion. This is extension. This is actually in a small child. And here you can see there is bifid arches of atlas. And here you see the fixation and the realignment of the region. So basically, for the craniovertebral junction and instability in this region, it all revolves around the C1, C2 facets. The whole function, the whole pathology in this region is based on the mobility in these facets. So coming to the next important one is the basilar invagination. So the earlier classification used to describe basilar invagination based on the presence or absence of Chiari, but this is the classification that we are currently using now and still going ahead from this classification. But let's start with this. So in group A basilar invagination, the odontoid goes up above the foramen magnum. It crosses the Wackenheim-Schliever line and the whole system kind of prolapses into the cranial base. So this is group A. There might or might not be Chiari with this. And in group B, the whole system consisting of the odontoid process and the clivus moves up. The odontoid actually does not cross the Wackenheim-Schliever line. And this is group B basilar invagination. And this was the classification described. At that time, we described for group A, a C1, C2 distraction and fixation and craniovertebral realignment. And for group B, we had proposed foramen magnum decompression. But as time will tell, our concepts have changed, and I will show you soon in the presentation. So this is actually what's revolutionized the treatment of basilar invagination, that the joints are abnormal. You see so many of these joints here. You see how the C1 is actually prolapsing over the C2. Here you can see that the C1 is actually in front of the C2. It has actually spondyloloptosed over the C2. So the whole pathology is that the joints are abnormally inclined and are mechanically unstable. The whole system is not fixed. It is mobile or hypermobile. And the instability is the problem, and stabilization is the treatment of this entity. Along with that, of course, if you can distract the joint, that is an added advantage. So here you can see the odontoid that has gone in. This is the C1, C2 joint, and this is after distraction and fixation, and you see the realignment. This is another patient having a little bit of Chiari, a syringomyelia with a group A basilar invagination. These are the C1, C2 joints, and you can see this is the fixation, and this is the craniovertebral realignment. So a lot of long-standing musculoskeletal changes like torticollis, like short neck, all these reverse after actually surgery for the region, after this craniovertebral realignment and stabilization, as you can see in this image here. We have moved further from this, and we have concentrated more on the facets, not on the atlantodental interval. And this is how we now classify atlantoaxial facetal dislocation. So if you see, this is type 1, where this we have seen already, where the facet of C1 goes in front of the facet of C2. This is type 2, where the facet of C1 goes posterior to the facet of C2. And this is type 3, where actually the C1, C2 facets are actually in alignment. And now you will see subsequently in the next few months, another paper that is describing how this is unstable, but I'm not going to be talking about that today. So both these, type 2 and type 3, we have now classified it as central atlantoaxial instability, that even though the atlantodental interval is normal, the facets may be malaligned by going posteriorly or may not be malaligned. It is the musculoskeletal and the neural changes that are markers of instability, and the treatment is atlantoaxial stabilization. So all these entities that you see in these in these circles around, like Chiari, syringomyelia, syringobulbia, C2-3 fusion, clipal file abnormalities, kyphoscoliosis, torticollis, bifid, orthodontoidium, short neck, basilar invagination, then external syringomyelia, and all these also subaxial problems are all related to this one entity, that is chronic atlantoaxial instability. And recognizing this instability and treating it is the key to the solution to all these problems. So this is our recent paper that we published last year, a review of our 393 cases treated over 12 years of central or axial atlantoaxial dislocation. So this paper actually consists only of group A CED, where there are, just a minute, yeah, the group A central atlantoaxial dislocation that involve musculoskeletal and neural alterations that are primarily associated with the craniovertebral junction. So this, of course, involves basilar invagination. We have not included this in this paper. Group B is the one that is associated with subaxial spinal instability, and Group C includes cases that are identified by discrete clinical observations without the association of any other musculoskeletal or neural alterations or any other defined pathological entity. So this is based on a high clinical suspicion, and if you can realize this entity and treat it, we'll be able to solve this problem. So if you see this image, there is a Chiari formation, there is syringomyelia, there is no change in the atlantodental interval, the facets are aligned, there is hardly any problem in the facets, as you can see here. And what we have done is we've just done a C1, C2 fixation, and this is the post-operative MRI. You can see that the syrinx has actually dramatically reduced in size, and the patient actually clinically improved significantly. So this is again another patient with a Chiari and a syringomyelia. You see there is a type 2 facetal instability. There is no change in the atlantodental interval on flexion and extension. All we have done is treated with a C1, C2 fixation, and here you see the reduction in the syringomyelia. Also, the Chiari has gone up a little bit. This is a patient with a group B CAD, where you see there is C1, C2 instability associated with some subaxial instability. The problem is not here. You have to recognize that this is the problem and you have to treat it. And intraoperatively, if you find that there are other indicators that show that this part is also unstable, then you treat this also. But you cannot neglect this C1, C2 instability. These patients present with severe myelopathy, and both these have to be included in the fixation construct. And you see the post-operative changes here. You can see that the disc has reduced, the cord has expanded, and the patient did very well after the surgery. And this is the last type of CAD, where you see that there are no markers. You don't see any Chiari, you don't see any syrinx, you don't see any facetal instability, but these patients present with a classical signs of spastic quadriparesis and indicators of craniovertebral junction problems. In this image, you see there is some rotatory instability, and this is one of the markers that can identify this, and you treat it with C1, C2 fixation, and this patient did very well. So this is just our review of all the papers that we've included, along with the new cohort of patients that we've included. And you can see the type of conditions that we've included here in this paper. All of these have central or axial atlantoaxial instability. These are the main presenting complaints: neck and arm pain, weakness and stiffness, paresthesia. There is a lot of patients who present with sleep apnea. They get up suddenly in the night with a disturbance because of the sleep apnea. They have this sudden awakening in the night. And some rare presentations like head dropping and diplopia. We have a couple of patients who have presented with just 6 nerve paresis. So just showing you a few cases which are examples of the central axial instability. So this is group B basilar invagination. Here you see that the whole system has moved up, the odontoid along with the clivus. This is the Chiari, this is the syrinx. You see the facets are in alignment. They've treated with C1, C2 fixation, and you see post-operatively delayed imaging showing the reduction in the syrinx. Again, another patient with Chiari and syringomyelia treated with fixation, and you see the reduction in both the Chiari and the syringomyelia. Again, another patient with group B, and you can see the results. The radiological results are one thing, but you get fantastic clinical results from the beginning, from the day after the surgery, and immediately the patient will say that he has seen an improvement in his symptoms. This again, group B basilar invagination with C1, no malalignment of the facets, but there is a Chiari and the syrinx, and you see in the delayed imaging, the syrinx is reducing, the Chiari is also going up. The next entity is Chiari. That is, now we have changed this philosophy completely for Chiari, and this is our last paper, 388. Now I think our experience goes about more than 500 patients with Chiari treated only with C1, C2 fixation without any foramen magnum decompression. So here you see there is no basilar invagination. There is a Chiari and a syringomyelia, and you see we've treated with C1, C2. The Chiari has reduced, the syrinx has also reduced. Again, another patient with no basilar invagination, a mild malalignment of the facets treated with C1, C2 fixation. You see the reduction in the Chiari and the syringomyelia. Again, another patient with no atlantodental interval change, slight malalignment of the facets, and you see the Chiari and the syrinx, which has reduced in the postoperative imaging, and the patient has clinically improved immediately after surgery. What happens when you have a failed foramen magnum decompression? This patient had undergone multiple surgeries, a foramen magnum decompression, a shunt, a VP shunt also, and then presented to us. So there is no other option, but you have missed the instability. And once you treat that, the patient actually did very well following the surgery. So, just for our information, during this surgery, we actually measured MEPs, transcranial MEPs, and it was, we noted that after the tightening of both the side screws, the MEPs actually went up 30%. And you can see in this image, the MEPs in both the sides and both limbs have increased. And that kind of, gives credence to the hypothesis that stabilization itself increases the motor function on the table, and the patient immediately improves after the surgery. And these are cases of idiopathic syringomyelia. Also, you have to recognize these patients. You have to rule out other causes like trauma, tuberculosis. And, if it is the craniovertebral junction that is the problem, you identify this and treat it with C1, C2 fixation, and you see the syrinx has actually disappeared. There is no patient did very well. Again, another patient, there is no Chiari, just syringomyelia, nothing in the craniovertebral junction. It is just a strong clinical suspicion. And here you see that the syrinx has reduced in the postoperative patient. So some of these fusions, C2-3 fusion, Klippel file abnormalities, they are all a protective response to craniovertebral junction instability. So you see this patient, there is no change in the flexion extension, not a marked change, but this patient came with severe symptoms. She had difficulty in walking, she had difficulty in speaking. Her voice was quite hoarse. She had sleep apnea. She used to get up in the middle of the night suddenly. And we treated this with C1, C2 fixation, and she's much better after the surgery, as you can see in this image. Again, C2-3 fusion is another indicator of instability. Here, this patient has both C2-3 fusion and a bifid arch of Atlas. So these are all indicators of craniovertebral junction instability, and you treat it with C1, C2 fixation, and the patient does well after the surgery. This is again another patient with pan-cervical vertebral fusion. We've had 4 or 5 of these cases, all treated with C1, C2 fixation. Another indicator of instability is this bifid, anterior and posterior arches of Atlas. So what happens is when there is flexion, there is actually, splaying of the facets, which causes the compression of the cord. And so the basic problem in this region is C1, C2 instability. And if you address that, you will be able to treat the patient. Patients having spinal kyphoscoliosis with Chiari and syringomyelia, again, treated with C1, C2 fixation. And you can see that the kyphoscoliosis has reduced in the postoperative period, and the patient has done very well following the surgery. And this is the clinical charting of our patients, the preoperative and postoperative clinical grades of the patient that you can see in our paper. Now, coming to the technique and how I do it. So this is the description given by Professor Goel. So this is the pars interarticularis in the C2 vertebra. The ideal entry point for screw insertion is this quadrant, the upper and the middle quadrant. If you insert the screw in this region, you will avoid even a high riding vertebral artery. So this is the most important anatomical thing that you should know when you're performing this surgery. The second important thing is the presence of venous plexuses and how to control. So the technique is basically opening the C1-C2 joint, denuding the cartilage, inserting bone graft pieces into the C1-C2 joint, and then doing a C1-C2 fixation. So this is the technique that I have performed, and I will just show you briefly. So this was a 12-year-old male child who presented with neck and back pain and scoliosis, and he had spasticity in all 4 limbs. So this is the image. You see the Chiari, a syringomyelia. Sorry. And here you see a subtle atlantoaxial instability. You see there is a very mild change in the atlantodental interval on flexion and extension. You see the facets are in alignment. This is a coronal image is important for seeing the vertebral artery. This is the position. So you can see this is a floating head position. The head is actually floating. It is not touching the headrest, and this avoids pressure on the eyes. This is the incision. So this is the C2 spinous process. So 4 centimeter above and 4 centimeter below the C2 spinous process. We use it under traction. We give intraoperative cervical traction, not preoperative. This is the incision. Now you can see that we have separated. This is the C2 spinous process, and the region is being exposed by subperiosteal dissection. This is the C2 lamina, and this is the going towards the C2 pedicle. So this is the region of the C2 ganglion. Suppose there is a high basilar invagination, we will transect the C2 ganglion. But if it is not very high, we preserve the C2 ganglion. So this is now I'm exposing the C1-C2 joint here in this region. So now you can see here. So the important thing is the venous bleeding. It happens in this region, in the region of the vertebral artery, in the region of the C2 ganglion, and in this epidural region. Now you can see that I've just seen the C1-C2 joint, and I'm drilling this area over the pars. And this is actually to prepare the host bone also, and also to place the plate nicely over the C2. So now you can see that I will enter the C1-C2 joint here. So this is the C1-C2 joint. The osteotome is in that. This is the C1 lateral mass, the inferior facet, and this is the C2 facet. So the first hole goes in C1. The direction is medially and towards the center of the C1 anterior arch. So sagittally upwards and medially. And now you can see that this bone graft that I've harvested from the iliac crest is being inserted into the C1-C2 joint. So try to put a lot of bone graft as much as possible. And this is the first screw that is going on into C1 along with the plate. And then the seat plate is kept over the C2, and again another hole is drilled under vision so that there is no damage to vertebral artery. And this is the direction of the screw hole, again going medially and sagittally. Then the plate is placed over the region, and then the C2 screw is inserted, and both the C1, C2 screws are tightened. And then we go on to the other side in the same way, expose the C2 lamina, the C2 pedicle, and then go towards the C1, C2 joint. Yeah, that is the C1, C2 joint that I have opened now. Then again, similarly, you will insert bone graft pieces and drill hole in C1. Here you can see the bone graft pieces are being inserted. Then the C1 screw goes in along with the plate, and then the C2 hole is made, and then the area is fashioned so that the plate sits nicely and snugly over the C1, C2 region, and then the C2 screw is inserted. And both the sides, the C1, C2 screws are finally tightened. And then the muscle from, now you can see how strong the fixation has become. The muscles are separated from the C2 spinous processes. And then the whole area is drilled to make it a suitable host for, fusion. Sorry. And then bone graft that we've harvested from the iliac crest is placed over the whole region. And then ultimately that is the fusion will take over. So basically the implant will hold it for 2-3 months. And then the most important thing is this bone fusion. So this is how I do the Goel C1, C2 fixation. And if all of you are interested, these are our various papers on the subject, which you are welcome to read. And I'll be happy to answer any questions. Thank you very much.
Thank you, Professor Peter Shah, and thank you for your nice lecture. So may I first invite our first discussant, Dr. Gib Danilov. Any comments from you?
Thank you so much. Thank you for a really detailed overview of the problem of craniovertebral joint surgery. I really appreciated that comprehensive narration. What I would like to ask is something related to the professional sphere that I'm interested in. Do you think if there are any application point for artificial intelligence or for computer science, any computer science technology in that in that type of surgery? Or I can ask another question. What are the challenges of decision making in that type of surgery when you consider multiple factors to make decision? Or is there a need for prognosis, or are there any tasks to automate some clinical routine work? After all of this can be a point for artificial intelligence application. Thank you so much.
Thank you, Gleb. And I think there is a huge role for artificial intelligence. Maybe, accumulating all the images and studying the anatomy, and then, figuring out the points of instability. That is one. And the other important thing that you have to study when, what comes to play is how the joints are aligned, how they are malaligned, how the vertebral artery comes into play, and how high is the basilar invagination. These are actually the factors that will determine the difficulties that you will have during the surgery. But the aim is to open the C1, C2 joint. And if you can do that, you'll be able to do the actual C1, C2 fixation.
Thank you.
Yeah, maybe any. Yes, Professor.
Abhita, first of all, congratulations. And actually, Indian neurosurgery is proud of what the KEM hospital had been doing right from the time of Dr. Dastu to Dr. Pandya and Atul, and now to you, carrying the legacy in craniovertebral junction, change the philosophy of the craniovertebral junction in whole world. We are really proud. This webinar is less to congratulate you. That is one. You are carrying the legacy far more than Atul has taught you, and Atul will be very, very pleased to listen to these comments about you. That is one. Keep it on, keep it on. Sky is the limit, above the Everest. Say, the thing is, one is about the type C. As you have told, in type C, the facets are not seen, say, problematic. The atlanto-dental distance is okay. What are those clinical parameters which are going to tell that the type C? I'll keep on asking one by one question, so you are not confused. Please tell me about it.
So basically, patient will have some history of mild or severe trauma some years back. there will be severe neck pain, there will be some spastic quadriparesis. Clinically, it will fit to a high cervical myelopathy. It will come completely to a high cervical myelopathy, and there will be no other cause for it. And then you will see some subtle changes in the facets. And I don't want to talk about that facetal changes because we are coming up with something, and within a few months we will be able to, elaborate on that. We are studying this, so how the others can actually study the instability and decide the C1, C2 instability and perform the fixation.
Pass on those changes which you detect. So
Yes.
I'll be able to
Yes.
incorporate in some teaching sessions. One is about that you also might have done, or you might have seen the patients in whom the ACM patients foramen magnum decompression must have been done. If you would have followed up those patients, have you really followed up those patients in whom the symptoms persisted or reappeared, and then you investigated the craniovertebral junction? Did you really find the instability in them?
So what has happened now, we were performing foramen magnum decompression for this years back. Like even when I was a resident, probably I must have done a few foramen magnum decompressions. So these patients themselves have come back to us on follow-up. At some times earlier, we used to say we cannot do anything. As we have said, how we treat, how do we explain to them, okay, your symptoms will not progress, they will probably arrest. This is what used to be told to them. But when these patients come back with, persisting symptoms or increase in symptoms, and we have treated them with C1, C2 fixation, they've actually done well. So, that is a very good encouragement for us to go ahead. We found instability intraoperatively in these patients, and we treated with C1, C2 fixation.
On radiology also, did you find the instability in them?
In some, not overt instability in some, but otherwise it was covert.
The patients who shows only syrinx and nothing else, how we are going to diagnose in them that they are the, say the C1, C2 is the cause?
So first of all, in our country, we rule out tuberculosis very thoroughly, that there is nothing related to tuberculosis. We rule out post-traumatic arachnoiditis. And classically, these people who come with syrinx, they're not very old. They are somewhere between the 20 to 35 age group. They have, again, symptoms pointing towards the craniovertebral junction. And a major finding in these patients is the neck pain. A major clinical suspicion, giving us a clue is the neck pain.
Again, is there any clue that he might be having something more than syringomyelia? Is there any more clinical clue which will direct you that these are the patients who are going to be helped?
So if you look at the facets, some of them will be aligned, but in quite a few of them, there will be posterior atlantoaxial instability. That will give a big clue.
Probably that will, again, you will be able to study in your newer thing which you are going to come out in. Okay, thank you very much. Nice, keep it up. Okay.
Maybe please first you raise your hands.
Thank you, Abida ma'am. It's excellent always. Actually, in Bangladesh, myself and my mentor always follow what 𝑹𝒐𝒃𝒃𝒂 said: instability is the cause and fixation is the solution. So in AED, in also cervical spondylitic myelopathy, we go for the facet screw as advised by the 𝑹𝒐𝒃𝒃𝒂. But in case of Chiari malformation, what we have done, as we have cath lab, so in few cases, we have gone for fluoroscopic movement of the neck. And in few cases, amazingly, we have seen instability in Chiari cases. So it also proves Goelser's hypothesis. So in those cases, we have done only the C1, C2 fusion. But in some Chiari cases, my question is, in some Chiari cases, posterior portion is very crowded, tonsil descends very low. In that case, we also did the posterior, foramen magnum decompression. So what is your suggestion regarding this case? This is first question. And second question is, how to, as a young neurosurgeon, how to avoid paravertebral bleeding while dissecting the C2 ganglion, the venous plexus bleeding around the C2 ganglion? Thank you, ma'am.
I'll answer the second one first. You cannot avoid the bleeding. You have to learn to work with it. There is no way you can avoid. You cannot coagulate everything in that area. You have to learn. You will learn as you grow. You will learn how to deal with that bleeding. And your first question is, see, you have started seeing instability in some cases where there was none, and you're fixing them and you're getting good results. You do it even, what happens is when the fossa is very tight and crowded, the surgery becomes more difficult. That's why maybe, you are a little bit hesitating and doing a foramen magnum.
Yeah.
So you try even in those cases, it will be a little difficult, but you will get the results. Even
Better
though
you go
Okay.
better you go hands-on with Avida sometimes, learn few
Yeah,
cases,
yeah.
then the anatomy and how to tackle the bleeding. So that's what she will
Yeah.
teach you on.
So, in few cases, what I have tried to do, I try to dissect under microscope from the contralateral side. If I am on the right side of the patient, I dissect it under microscope on the left side of the patient. So in this way, I have limited the bleeding paravertebly.
what you should do is just try to rapidly do it and, insert some Surgicel and gel foam in the area and learn to work a little bit with the bleeding, because it's going to bleed. There are 3 or 4 areas where it just bleeds. And,
Exactly.
after you go and try to control it, coagulation will not work in majority of the times.
Okay. Thank you.
Yes, Dr. Alisha, you raise up your hands.
Yes, thank you. This was very good and informative lecture. So my question is, like in our setup, we use screws and rods, and I saw this plate for the very first time. So is there any difference in the results and any post-op pain to the patient in rod fixation or the plate? And second is, what about navigation regarding protecting the vertebral artery, neuronavigation perioperatively? And yes, we can do pre-op images as well to know the landmarks, but still, do you recommend using navigation for it? And
Sure.
third, like this question was previously asked, but still it is unclear. Like if we do a foramen magnum decompression and a patient comes, so the protocol should be, we should fix the C1, C2, whatsoever, even if there is no instability. Thank you.
For us, the protocol is changed that there is no foramen magnum decompression now, just C1, C2 fixation. Our old patients who are coming with foramen magnum decompression now, yes, old patients who are coming with foramen we are treating with C1, C2 fixation. That is your third question. Second question is navigation. Yes, as a young person, you can use it. It helps to give you the direction of the C2 screw. But it is better that you start, doing the anatomy. It becomes very simple. You will not even need fluoroscopy as you progress, but definitely navigation can be used as, if you're inexperienced in the beginning, it will of course help you. And your first question is, I have never used a rod. I have always used a plate. And if you realize that the plate actually sits on the bone, the screw and the plate sit on the bone, the rod is actually away from the bone. So the biomechanically stability of a plate and screw construct is probably higher than a rod and screw construct. But I don't know about the pain and all that because I have never used a rod and screw construct.
Okay, and also, Professor Priestess, any comment from you, Professor Priestess?
Thank you. Thank you, Professor Abhidasha. Congratulations and for your achievement and excellent presentation. We're proud of you and Professor 𝑕𝒂𝒂𝒄𝒄. Thank you very much.
Thank you, Dr. Pirzad. Thank you.
And thank you so much for your talk, Professor Abhidasha. And for our first speakers, he's not available today due to emergencies. And I think maybe any comments from Professor Kato, or we shall end this webinar slightly earlier.
Okay, thank you very much for 15 speakers. Unfortunately, we cannot have Professor Ahmad, unfortunately. But I think the first speaker from Italy, the Cera, I think intercranial pressure is very, very essential issue for all neurosurgeons, especially the trauma case, I think. Sometimes we want to know how long we can sustain it, how long we can wait. Or sometimes the intracranial pressure is more than, or the CPP is more than 60 millimeter mercury, and how long the brain can tolerate for such the bad condition. I really want to know, because of course, as soon as possible, we need sometimes with decompression surgery. But I think, Chiara, thank you very much for a nice presentation.
Thank you.
So, can you understand my question?
Yeah, I understand, but I mean, the guidelines are telling us that we need a CPP higher than 60. So lower than 60 is a huge problem, which is time dependent, and you have to treat it as soon as possible. CPP higher than 60 to me is a standard of care, which I mean, it's something that I try to achieve actually. Of course, you have to be careful not to have a too high CPP in order to avoid the hyperemia. And this is the other side of the coin, and this is where you can discuss about the higher limit of autoregulation and etc. But for sure, I would avoid hypotension.
Okay, thanks a lot. So please continue your research in the future. So let us the more information. Thank you very much. And Amitasha is always the excellent talk. I think maybe some how to boil the surgical technique which you succeed. I think it is very nice, but we should be very careful with the vertebral artery sometimes. I think the two great lectures that we learned a lot from them. I think Dr. Danilo, the long time no see, but thank you very much for your great comment. So maybe the next time you can give us another AI talk, please. Thank you so much, and also the present.
Thank you so much.
As always, thank you very much for your comment. Thank you so much.
Thank you.
Back to Ben.
Yeah, so, and thank you so much for all of you to join us today. I think we shall end today's webinars and slightly earlier. And first of all, I would like to thank you, Professor Peter Schatz, again for your lecture and also chairing the section. And also thank you, Professor Roberts, and for your lectures. And thank you. Also, I would like to thank Danilos and also Priscilla for moderating and discussing and commenting the lectures for us. And also thanks to all the audience today. Today we have more than 300 viewers in the China WeChat channels, and thank you so much again. So I hope to see you in the next ACNS YNS webinars again on the 21st of June. And until then, it's a bye-bye to all of us, and thank you so much.
Okay, bye-bye. So this shot, are you okay?
Arigato. Arigato gozaimasu.
Hi. Okay.
Sayonara. Sayonara.
Sayonara. Sayonara. Oyasumi.
Goodbye.
See you again.
Assalamu alaikum.
Hi.
Assalam.
My colleagues, so good night. Oyasumi.
Okay.